Celiac disease is one where we've been doing things in the reverse order. So this is a disease where people have sensitivity to gluten. So whenever they eat foods that contain gluten, their bodies react, and then symptoms develop, and then of course it leads to complications. So there are tests that can be done to make the diagnosis. So typically what happens is patients come to see us, and we suspect maybe there is gluten sensitivity based upon their symptoms, and we order the test. And the symptoms include mostly gut symptoms, but also symptoms outside of the gut. And the gut symptoms are, of course, gas and bloating and diarrhea, and symptoms of malabsorption after eating foods that contain gluten, which is basically going to be wheat and barley and oats and stuff like that. Now, when we suspect the disease, we order the test, and the test basically includes multiple antibodies. So there is a panel of antibodies that we do, and those are basically IgA and IgG antibodies against gliadin, and then tissue transglutaminase. So there are fancy names involved, and we do these tests, and if the tests are positive, then we say, okay, maybe gluten sensitivity is present, and then after the endoscopy is done and the biopsies are taken, then the diagnosis of celiac disease is established. However, there are two caveats in establishing these two diagnoses. One is that if the patient has avoided gluten leading up to the test in the most recent 2 to 4 weeks, then the test is going to be negative. So, or in other words, the body's immune system is not going to make antibodies, and we will be blindsided by it, and we'll suspect that maybe we'll say the celiac disease is not present. However, it's just because the patient did not eat gluten. The second caveat is that there is a subset of population that lacks the ability to make IgA antibodies. So IgA antibodies are specific antibodies that everybody has, and some people just have very low levels of the IgA antibodies. So if they don't make sufficient antibodies, then also they are not going to mount a response to the gluten protein or the gliadin protein, and as a result, we will not be able to detect the disease. So given these two caveats, it's important to keep in mind that celiac disease or gluten sensitivity can still be present even if our tests are not showing positive. It's more important to take a look at the patient's symptoms and also how they are reacting to the foods that contain gluten. The extra-intestinal or the manifestations of gluten sensitivity or the symptoms that are outside of the gut are those that include largely skin. So there may be skin rashes, there may be fatigue, people may develop headaches, people can also have brain fog, and in severe cases, complications. For example, they can have ataxia or difficulty with balance, and then they can have all kinds of symptoms that are related to malabsorption of other nutrients because of the damage to the intestinal wall. So there's a long list of symptoms that can be present. Now, the reason why I'm saying that we are doing things in the reverse order for celiac disease is because celiac disease is highly genetically determined. So there are two specific genes that determine whether somebody will develop celiac disease or not. And these are HLA-DQ2 and HLA-DQ8 genes. If these two alleles are present, then there is a very strong likelihood that the patient will develop in their lifetime, not necessarily early on, but in their lifetime, will develop celiac disease or gluten sensitivity. Now, consider this, in general population, in our Western population, about 25% of the 25 to 35% of the population has at least one or two alleles of these two genes. So if they have if the prevalence of these two genes is this high, we can say that about 1 in 4 people, or 25 to 35 out of the 100 people, have at least 1 to 2 genes. So they are going to be at risk for developing gluten sensitivity or celiac disease. Not everybody, however, having the gene does develop the disease. So because the prevalence of the disease at this point is about 1%. So when we know that there is a genetic predisposition, we can do genetic testing early on in life and avoid a lot of suffering, because currently the model that we have is allowing for a lot of suffering. So the way we are diagnosing celiac disease based upon the symptoms and based upon our clinical suspicion. By the time we do all of this workup, patient has already suffered a great deal, and many years of suffering have already passed. Typically, people spend about 2 to 3 years figuring out what is really causing the symptoms. And finally, they get to see a doctor, and sometimes doctors don't suspect it because the range of symptoms is so widespread. It's such a multi-symptom, multi-system disorder that the diagnosis can be easily overlooked. So such a great suffering happens, and people go through all of that and then finally get the diagnosis. But if we do the genetic testing early on, at least we can predict or we can suspect this disease very early on and avoid the suffering. Now consider 2 scenarios. In scenario 1, there is a patient who had the genetic testing not done but had the genes, and nobody tested this person, and he or she continued to consume gluten-containing foods and eventually developed symptoms in their 30s or 40s, and then developed complications, and then finally got to see a doctor who tested appropriately, and then ended up getting the diagnosis, and then of course had to avoid gluten altogether for the rest of their lives. However, by now you can see that this person has already suffered, and this person has already developed multiple complications related to the malabsorption, related to the damage to the intestinal wall, and related to the target organ damage. So we have not been able to avoid all of them, and the person is now basically somebody who is sick with the disease. Now, scenario number 2, another person who has the genes, and we did the testing. Now this person now has information about their genetic makeup, and so they make an educated decision, and they decide that, okay, I'm not going to consume gluten, or I'm going to consume it very, very minimally. And as a result, their genes are not exposed to the trigger, which is the gluten, and hence the epigenetic expression is not happening. So the genes are not expressing themselves, and the person actually does not develop the celiac disease, or if does, develops it very, very late in life. And of course, more importantly, the symptoms do not occur, and also the complications do not occur. So we can avoid so many years of symptoms and also the complications and the quality of life ultimately for these patients. So therefore, I suggest that genetic testing be done early on in life for this particular disease, because there is such a great deal of quality improvement in the quality of lives of patients that can be achieved with this particular testing. The reason why we don't do the genetic testing is twofold. One is that the guidelines don't recommend yet that we do the testing unless there is a specific population. But we must keep in mind that guidelines change, and there are things that we do as we make progress in science and technology. So in the past, for example, we didn't used to check everybody for cholesterol. We didn't used to check everyone for blood pressure. And but now for coronary artery disease and cardiovascular problems, which are the leading causes of death in the world, we are routinely testing blood pressures and cholesterol. And we're going as far as doing the advanced level tests, for example, coronary artery calcium scores. We are doing stress testing in populations where we suspect this problem. So technology has allowed us to do all of that, and the guidelines have basically caught on to make those recommendations. Just like that, for diseases where we can prevent a lot of different things and complications, guidelines will eventually catch on. The second thing is, so we should always look ahead. The second thing is that the genetic tests are notoriously expensive, but as a matter of fact, the HLA-DQ2 and DQ8 allele testing is really not all that expensive. And also, we must keep in mind that as we make more and more educated decisions and do more testing in a wise manner, looking at how these tests are helping us improve the quality of lives of patients, the cost will come down, because of course there is an economy of scale going on there. So the cost should not be a factor when it comes to making the right choices. So therefore, I do suggest that for the quality of life of our patients and also our community and our society, we should definitely pay attention to this particular testing for celiac disease.